Hello everyone, my name is Mian Letienne and this is a poster presentation on using machine learning models on imbalanced data from a clinical decision support system to optimize multidisciplinary tumor boards for the management of breast cancer patients. The premises of this study is that multidisciplinary tumor boards, or MTBs, have improved the management of cancer patients, notably by assisting clinicians in applying clinical practice guidelines, or CPGs. OncoDoc, a clinical decision support system, or CDSS, was built on CPGs for breast cancer patients to propose personalized treatment plans according to patients' data. It was used in MTBs at the Tenon Hospital in Paris, France, for 2 years and a half, and during its use, compliance to CPGs were visibly improved, but 8.3% of cases remained non-compliant, and clinicians did not agree with the proposed treatments. In those cases, patients' profiles were either too complex or presented personal issues, medical issues too specific for CPGs to handle. In this study, we assume that non-compliance to OncoDoc is a sign of case complexity, and we will refer to those non-compliant cases as complex cases. The study objective is to use machine learning to identify complex cases from non-complex cases. This includes comparing multiple machine learning models and using and comparing multiple samplers to handle the data imbalance in our dataset. The goal is to correctly identify complex cases, which are the cases non-compliant to OncoDoc, ahead of MTBs to optimize workflows so that clinicians can treat non-complex cases quicker and focus more time on complex cases. We had an original database of 1,887 decisions with 127 collected variables, which we cleaned, modified, and trimmed down to 70 variables. The final database was used for all the analysis and underwent the following standard procedures. Stratification, which was used for class complexity to keep the ratio in our testing and training datasets. Five-fold cross-validation was used to have a more accurate evaluation of our model's performance. Hyperparameters tuning was conducted for all models. And lastly, feature selection was also used to select the variables most relevant to each model. What it means is that when models are trained, it is possible to evaluate how important each variable or feature are to the model performance, and feature selection helps select the most useful one. So here are the samplers and models used to correct data imbalance and then classify the cases. We tested 5 samplers, which one way or the other correct data imbalance by sampling either the class minority, the complex cases, or the class majority, the non-complex cases. So random undersampling, or RUS, randomly deletes instances in the class majority, whereas random oversampling, ROS, randomly duplicates instances in the class minority until both classes have equal size. Addison and Smote help generate new instances in the class minority by observing the profiles presented in the class minority and creating an estimation of what they think could be a similar profile in the minority class. Smote EN does the same, but also deletes instances to help diminish redundant data. For machine learning models, we have decision tree, random forest, and XGBoost, which are all decision tree based models. Then all samplers combined with the models were evaluated using recall, precision, and F1 score. Here is an overall view of the analytic process. So first, the dataset is refined into the study dataset, and then stratified and split into 5 folds. For each split, we used the samplers on training datasets to compensate data imbalance, and then trained and tested each model for classification. all hyperparameters tuning and feature selections were conducted at this point. Lastly, all combination of samplers and models were evaluated and compared. So here are all the F1 score observed for all combinations of samplers and models. So each column represents one model. Here is decision tree, random forest, and XGBoost. On the left-hand side, we can see all the samplers and when we used none. And we can see that decision tree and random forest had their best F1 score with ROS, random oversampling. Decision tree had 37.4% and random forest 33.5%, and XGBoost performed best with random undersampling at 38.1%. Overall, XGBoost presented better results than decision tree and random forest, but it was still insufficient to have an exploitable model. We can also see that using samplers does not always improve F1 score. For example, RUS decreased F1 score for decision tree from 28 to 24.3%, and RUS, ADASIN, SMOTE, and SMOTE-N also did not improve performance for random forest. In summary, we did not obtain models with sufficient performance to classify complex cases with globally low F1 scores. We tested multiple samplers to correct data imbalance, combined with standard optimization techniques, such as hyperparameters tuning and feature selection, but we didn't get enough improvement to have a usable model. In some cases, using samplers even worsened model performance. So there are several possible hypotheses for those results. First is that we define complexity as non-compliance with OncoDoc, and we acknowledge the limits associated with that. For example, complex cases which eventually were compliant with OncoDoc after a long discussion between clinicians are not identified in our study and are only identified as non-complex cases. Likewise, in some cases, treatments are dismissed right away, for example, when it goes against patients' preference. But they are labeled as complex and when they might not be really representative of complexity. Further analysis and reviews of MTB decisions might give us a more accurate definition of complexity for additional studies. Lastly, we believe that we could improve the current results by using deep learning, as it is known to improve results compared to machine learning, especially on imbalanced dataset. And we also hope to improve our data processing, as we might have oversimplified our original dataset. Thank you for your attention.